things that are typically related to mental health problems like suicide and HIV, which is related to our behavioral issues as well as the social context, these are all intersecting at this particular sensitive period of development. So that's the global context that I want to give to you. Now I'm going to make a plea. The plea is that as we talk about the ways of intervening to make healthier, longer lives, that we talk both about health and about risk. I start with this. I don't know how many of you have heard the problem of the single story. You may have seen the TED Talk that Chimamanda Ngozi Adichie has done. If you haven't seen it, you should watch it. But she talks about the single story, which is that often there's a single story that defines people who have less power in societies. And this tends to be often minority groups in a given context, and certainly around the world, people with severe mental disorders would fall into this context. And the consequence of the single story is this, she says, it makes people incomplete. I think in the context of certainly the way that we train mental health professionals, the way that we're taught to think about our patients, this is a missing piece of that story. Thinking about people's relationships, their intimate lives, their sexuality. There's a part of that that's important because it's about risk protection, but there's a part of that, a larger part that's even more important because it's about having a whole life, and it's about a way to engage. In my work before I was at NIMH, I had the opportunity to work with a lot of women living in New York City with chronic mental disorders, and to have conversations with them about both HIV, risk and protection, but also simply about living with a mental illness. What does that mean? What does that mean in terms of your relationships? What does that mean in terms of the decisions you make? And what does that mean for your health and well-being? So I want to just make a plea that this is something that we think about. I think one of the reasons we don't think about this is because of stigma. Stigma is a discounting issue. It allows and fosters policy and attention toward the concerns of stigmatized groups. So we need more of these conversations, and we need to do them from a gender lens. And finally, I just want to say a few words about Seattle. I'm new to Seattle, so I'm going to give you some remarks that are from my colleagues Lydia Trosiak and Dror Ben-Zev, both at the University of Washington. This is Seattle. It's a beautiful city. It's a wealthy city, but it's a city that's rapidly changing. Homelessness is a significant problem in Seattle. Seattle is also a city where, the state of Washington is a state where marijuana is legal. There is quite a heavy drug-using culture in the town. There's a tremendous opiate epidemic as well that's quite visible on the streets of Seattle. And it's a rapidly shifting socioeconomic situation. It's the city that has led in growth among large cities in the United States for the past decade, which means that there have been an influx of people. And what this has led to is really a concentration of disparities in Seattle, so that you have increasing inequality, increasing risk for more vulnerable people. And Seattle is a city with a lot of young people. There are many universities, there are many immigrant communities moving in, a lot of young people. So again, a place where there is a lot of opportunity. As Moitreyee said, cities bring risks, but they also bring resources often. So we've got that mix in Seattle, the opportunity for getting engaged in things that are likely to harm your health, but also the opportunity for some resources that may not be everywhere. So my colleagues at University of Washington are building on the RAISE program, developing first episode psychosis care there, and I think we'll hear more about this during other portions of this meeting. But this is really treatment that bundles both pharmacology, case management, family education, this coordinated specialty care, resilience training, supported employment and education, and peer support services. This leads to greater reduction in symptoms. We know these data. So this is important to do. There are current gaps in this kind of access to these services in Washington State, as well as engagement in services. And one of the big issues, substance use disorders and cardiovascular risk, are not yet addressed. So in the context of Seattle and Washington State, the issue of drug and alcohol use are huge. These are the leading risk factors in our state for poor outcomes and for mortality. And the vision here is to be able to have these lovely continuum of care that promotes access, provides the evidence-based care, treats the whole person, including those issues that are really about promoting a healthy life and enabling people to achieve a higher quality of life. And just in the last slide I want to show is that there's a role for technology in this as well. Dror Ben-Zev and his colleague Benjamin Buck are working to see how they can use media resources for both families and people with first episode psychosis. So this is an act that you will see the continuing portions of in the future. So I just want to acknowledge these colleagues and thank you.
Thank you so much, Pamela, for that wonderful, plethora of interventions that have already started in Seattle and the challenges that you're going to face. And I think we'll listen to more about that. I'm going to move on to Tasneem now and to ask Tasneem a little bit about the kind of innovations that you brought in a city which didn't really have too many resources. So Tasneem has worked in, like I said earlier, in a place called Nagpur in central India, a large city, lots of migration, worked in a mental health system which was very rudimentary, which did not have too many resources, and has completely turned things around and has become like an exemplar of how things can be done. So I'd like Tasneem to talk a little bit about what you've done, what you've achieved in the face of very challenging circumstances as well.
Thanks, Prabha. First and foremost, I thank the organizers for having us here, and it's really exciting to be part of this conversation. And thank you, Moitreyee and Prabha, for this panel as well. I represent an organization called the Tata Trusts, which is India's largest and oldest philanthropy, and we have worked in mental health for several decades with very pioneering partners, including people on the panel here. So the program in Nagpur is a collaboration between the Tata Trusts and the government, and it spans two different and large aspects of work. The first is to reform a psychiatric institution to basically showcase what psychiatric institutions in today's day and age and for today's service users should really look like, and how should they cater to the needs of service users today, because we know that, and we heard it in the morning, that closing down institutions can parallelly lead to increased population in prison with severe mental illnesses without access to care. So probably closing down institutions may not be the best way forward, but the institutions of today definitely need a different role, need to play a different role. The second major program that was recently launched is a huge community mental health program, again with the government of Maharashtra, to showcase what community mental health should really look like, an end-to-end program for 5 million people in the district of Nagpur. It is, I believe, one of the first programs at this scale where we are actually doing screening of, the aim is to cover 100% of the population through individual screening. Like I said, the challenge is it sits in collaboration with the government program, and it aims to strengthen the system as the program goes forward, using government resources to the maximum. So the people actually doing screening are government incentivized frontline workers. Evidence that has come from various RCTs, including Vikram's work in India, which shows that it is imminently possible to do this. It's just taking all that evidence to the real world and doing a scaled program. Now, of that 5 million population, almost 3.5 are in the age group of 14 to 49. So that's a lot of young people there. The strength of this program, on the one hand, is it's a government collaboration. On the other, by virtue of being a trusted philanthropic organization, we bring to bear a multitude of stakeholders and partners. I'll give you a few examples of that. So we are an industrial house, and the in-house companies are one major stakeholder that we have been able to engage in our programs. A simple example of this is TCS giving us 30 volunteers every week to work with our young people. And it's simple things like computer training, which a lot of young people want to engage in. And instead of talking illness, it talks wellness. So it gives people a chance to interface with other stakeholders and to engage with them. And it gives us an opening to talk to these young people. The other thing is, while we've entered the system through the mental health element, we use every aspect of health, social justice, disability, and other schemes of the government. One example of this is the vertical youth program that the government, the youth health program that the government has, with the acronym of RKSK. It has resources. Those resources can be used to bear upon the program for mental health and well-being for young people. Like Prabha mentioned, while Nagpur, for a lot of reasons, has a lot of political will to bring in development programs, it is not a very well-resourced region. It is also a region, part of a region that has a lot of agrarian distress and suicide. On the one hand, there are a lot of opportunities to engage and work with people. On the other, there are immense challenges. Working with the system itself is an immense challenge. A bulk of this region is urban. So of the 5 million, almost 4 million are urban. So, and yet there aren't many jobs. There are not many educational opportunities. So with resource limitation and the aspirations of the young, there is a certain gap that exists. And the need for mental health services is extremely high. And as we speak, screening has begun on ground with the training of the government frontline workforce to do it. 2,000 people have been screened. And of the 822 individual profiles that have already been analyzed, 409 people were found positive for mental illnesses, of which 217 were severe mental illnesses. The proportion is very, very large, and so honestly, we don't know what we have taken on by this program. We just hope that all the expertise in this room and all our partnerships will come to bear in making this program a success. I hope I've answered some of your questions. Thank you.
Thank you so much, Tasneem. It's indeed been extremely inspiring in the context of India to see not only the work that's been going on for many years in places like Chennai, Bangalore, but also all of the new work in Nagpur, Pune, and so many other places. And with that, we are going to segue, and we are extremely honored to have Dr. Njuguna with us here today. And we were talking about, huge increases in population. So Kenya, from 1963 till now, has gone from 9 million to 49 million people. And about 60% of the population is younger than 24 years of age. And Dr. Njuguna has, as the head of mental health for the country, has a huge amount of responsibility there. And Dr. Njuguna, thank you for joining us. And it would be wonderful to hear from you about how you're thinking about how Kenya and how Nairobi, in the context of Kenya, how can it leverage on work that's already happening there? How does it harness all of that specifically to support people with serious mental illness? What are some of the things that's happening already? What are the things that you're looking towards doing? If you're able to share that with us, that would be wonderful. Thank you.
So thank you, Moitreyee, and the organizers of this conference. As you have heard from Moitreyee, we have a population, and this population is majorly consists of the young people. And what has happened in the recent past is we come up with a policy, mental health policy. And with this mental health policy, we had to think of how do we go about implementing this policy, because there's one thing about having a policy and implementing the policy to bring the transformation you want. And what we were able to get from our policy is, so what we are able to get from our policy in terms of status analysis is that there are major treatment gap within the population, going as high as 80% treatment gap. And going with that is also the limited resources. And when we looked at what are the barriers or some of the contributors to these treatment gap and limited resources, we saw that there was the issues of stigma and discrimination and lack of mental health as a public health agenda. And so we had to come up with ways in which we can be able to achieve the objective of our policies by coming up with strategies which are not as business as usual. You don't do things in the traditional way. We had to reframe the conversation about mental health. And the focus, we realized the focus has to be to the young people because they consist about 60% of the population. And from what we have heard, that severe mental illness tend to start before the age of 25. In about 75% of the cases, it starts before the age of 25. So we realize the focus has to be this key population of the young people, because we look in terms of socioeconomic development of a country, we need to put a focus on the young people. And so around this time, citiesRISE came to become one of our partners, and we started some collaboration with the citiesRISE. That's sometime back in 2016. And we thought, how do we go about doing things not business as usual? We need to do things different, because severe mental illness tend to begin at a very early age, and we want these people to live healthier and longer lives with quality of life, with good attainment and productivity in their life. Then we need to focus on the young people, and then we are able to address the issues of mental illness, and they're able to have a quality of life and live long and healthy lives. And we realized one of the key challenges among the young people was access to service. Because traditionally the service has been designed more for the elderly people or for the older population. Again, are we giving services to the young people within their spaces? So we thought here we need to do things in a different way. And so we started reframing the conversation of mental health. And our reframing, we came up with these strategies that will focus on the issues of increasing mental health literacy, that people get to know about mental health, what is mental illness, and the dimension perspective about positive mental well-being and mental illness. And we found this is a better conversation rather than approach the young people talking about the mental illness, and then also talking with the same kind of language to their parents and the people within the community. Again, we thought we need to leverage on other health platforms, especially trying to address the issues of mental health parity. Sexual and reproductive health is a key element among the young people. So can we use the existing infrastructures and health platform as we are developing some user-friendly services for the young people? So we have come up with youth-friendly clinics. These youth-friendly clinics not only address issues about mental health, they address issues about sexual and reproductive health issues, they address other health issues for the young people. Then we also thought, what other model of care do we come up with? We thought we need to focus or take care to where people are, rather than people go to the hospitals. So we thought of having services within the community-based mental health services. And because of the limited resources in terms of the workforce, in terms of all other aspects of health systems, we thought we need to do what we call task sharing, train people within the community that they can be able to educate the people within the community, they can be able to do screening and early diagnosis. We also train the young people who speak the same language with the other young people, that they can be peer educators, they can be peer counselors, and they start the conversation about mental health within the community. So that was another shift in terms of the model of care. And then innovation in terms of utilization of technology. Internet connectivity in Kenya, it's very high. As we see in terms of the other resources are limited. This is an opportunity, this is a strength within the country. Can we have the conversation about mental health and severe mental illness within the internet platforms, within our young people? And so citiesRISE, as they came, we have been designing and started the implementation of the program, the citiesRISE program within the Nairobi city, where we are utilizing these issues about reframing the conversation about mental health, health, and trying to address issues of stigma, taking the care to the young people, providing spaces for the young people, which not only make them have a conversation, but also make sure that they start conversation about mental health, not only mental health, about HIV/AIDS, sexual and reproductive health, in an integrated way that they don't just see themselves, they're just talking mental health. And more to that, we go on to the issues about NCD, because you look at some of the risk reductions, they will apply across the different health conditions. Exercise, they bring issues about promoting mental health, issues about weight management, healthy diets, prevention of substance use. So that kind of a model is what we are working with citiesRISE, and we think it's going to help us even with the limited resources, but also taking advantage of the strength we have in terms of technology, people living within the community to address issues of severe mental illness and try to see that this key population, which is the major population within the country, can live with severe mental illness, can live quality life, a longer life, and be productive. Thank you.
Thank you. So I'm going to go next to Yvonne, and so Yvonne is somebody who's, you know, a youth leader, an emerging youth leader in Nairobi, has harnessed the whole power of youth, and like we heard from Dr. Njuguna, the young people form the majority of the population in Nairobi. And Yvonne, I'm going to request you to basically take us through your journey of becoming a youth leader in the area of mental health. How did it all happen, and how do you see the future in terms of engaging young people with severe mental illness into your program?
Thank you, the conference organizers, and thank you, Moitreyee and Prabha, for having me here in this panel. So I'm just going to say that I was born in Nairobi in one of the informal settlements. And if you hear about informal settlements, what comes to your mind is about poverty, unemployment, illiteracy, and semi-illiteracy amongst the population there, and especially for the young people who live there in that place. So in the area that I was born in, we also have it's closest to the biggest drug den in Nairobi, whereby many young people get into substance abuse and opioid use in the community. So when I was growing up there, it reached a point in my life whereby I underwent a severe depression, and I did try to commit suicide. So during that time, I didn't even understand what I was going through. I was taken to the hospital. So the most interesting thing is that the doctor then asked me, so you wanted to commit suicide. You should have just come to me and told me what you wanted. I could have done that for you. So leaving the hospital, going back to school with so much pressure. And I felt during that time that the society had failed me. I didn't have family, and the social support within me was really limited to help me through what I was going through. But then, as I continued to grow up, I realized that this is not only a case for Yvonne only. We have so many young people in the community who are undergoing these kind of challenges, and the system there around to help them is not being felt. So realizing that I had undergone depression, I didn't even know the language or the term to explain to somebody else who doesn't understand English. Because some of the terms in the mental health field are English-based, and not many people understand what it means in their local language. And when you talk about mental illness in Kenya, it's related to spirituality. So some people will always tell you that you are bewitched, or it's about witchcraft. So instead of seeking help, what happens is that we always run to spiritual leaders to seek help. And that is when you find that we always get these cases where somebody has been chained, because it's like exorcism, taking out demons from that place. People are quite ashamed of who they are. And if you are a young person, your parents don't even want to be associated with you. So that is when we decided as Mbari Africa, why don't we take up this challenge in the community, find a palatable way of increasing mental health literacy and awareness in the community. So we could not do it as the usual way of just going and talking about it. And yes, the policy was there and very supportive for kind of initiatives that we could have come up with. So we decided to find a way using creative methodologies. So we have these puppetry shows and live skits whereby we just go into the community, Huruma being an area that has a huge population. So we find different spots that whereby we just put up the booth, we narrate a situation that happens in the community from the stories that we collect. And then we are able to engage the community itself and encourage people. Whoever wants to seek help, we are able to refer them to treatment. And some of the people in the community, the treatment centers, some of them are youth-friendly. So we are in like a contract with them to help these young people in the community. So apart from that, we also have these radio talk shows, which are quite community-based. So in that platform, it reaches up to 90,000 people. So we are able to talk about different issues, different time, during different segments. So with that, we've seen quite a huge increase in literacy of mental health awareness. And I believe with that methodology, we can also still use that to rally and galvanize support for mental illness so that we are able to shift the narrative and stop looking at it from our spirituality aspect of it, but see that these people are part of us and see how we can include them in the society. And also as Mbari Africa, we decided that we also don't have a place, being that it's a place where it's trained with resources. Most of the community members are underprivileged. Why can't we also have a space whereby these young people can always come and talk to their peers? Yeah? There's music, there's dance, there's plays, anything that feels comfortable to these young people so that they're able to feel part of the process. And then continue to encourage each other as they go through this process. And apart from that, we also into contact with their parents. So we're able to talk to them, to encourage them, because at times, like I mentioned earlier, when your child has been diagnosed with a severe mental illness, the society will tend to shun you. So they feel quite lonely. So these are some kind of initiatives that we've been able to do. And I believe with galvanizing support from the youth leaders or young people across the world, we can always find innovative and creative ways whereby we can even reach more people with this mental health literacy and awareness.
Thank you, Yvonne. Thank you very much. As you can see, the enthusiasm of the youth, and I think we need more of them in our community for being advocates for mental illness, not just in young people, but through the lifespan. Thank you so much for sharing your story, Yvonne.
Yeah, thank you so much. I think one of the very important elements of the type of transformation that we've been talking about, one is the importance of changing the systems, but there's also the importance of more of that social movement. And I think the leadership of young people with their insights, energy, creativity is a key piece of that. And so a lot of the work that Yvonne and other young leaders are doing in Nairobi, we are seeing similar things now in many, many other cities. And one of the things that hopefully we can all do is to see how we connect and provide a bigger platform for these youth leaders. With that, we are going to segue and ask Gary to tell us a few things. It's very hard to think about cities and mental health and not think of Gary and the amazing work that's happening right here in New York City. And I think there's a number of things, Gary, that would be very interesting for you to reflect on. I think, first of all, the boldness of the vision, your own vision, Thrive NYC, and how cities thrive, what are you envisioning there? It's something that's been a trailblazer in how cities can take a leadership role in a very, very difficult subject. We would love to learn more about how did you bring so many different stakeholders together? How did you break all those silos? And what are some of the very specific examples that you can provide that's happening right here in New York City that are very relevant for serious mental illness? And what can we learn from New York City? What has New York City learned from other cities? So if you don't mind sharing some of that, that would be wonderful.
So that's a short list. I'll do what I can in 6 minutes. I really appreciate the opportunity to be part of this panel, and especially that it's a global panel. As I'll get into a little bit, we've learned so much. We've stolen so much from other parts of the world and what's in Thrive. Experiences I had in Kisumu, Kenya, and other parts of the world, Haiti, really showed me how mental health could look different. That's where I came across task sharing, understanding that communities had to drive this, that we had to really start over how we understood mental health worked and who was included in that work. And a lot of that is in Thrive. The North has as much to learn from the South as it has to share. Actually, I think it's more so. And that balance. So, your first comment, how did you get to be so bold? I think, the reason why this bold idea, and just to give people who aren't familiar with Thrive NYC just a sense of the ambition, there are 54 specific initiatives. The first 4-year cost has been estimated about $800 million investment by the City of New York in a really frontal approach, public health approach to mental health. And I think that boldness was really due to the fact that something less bold would not have gone anywhere. And that was really an important lesson. I felt empowered as somebody who'd been in this field to be unambiguous and unashamed, to talk about how large we had to think about this issue. That it had to involve all of government, all of our agencies, it affects all of society, every family's affected, everyone's affected. These aren't the mentally ill people over there. It's all of us. And what does that mean? What does it mean to really grapple with this as the 21st century public health priority that it is? And what can a city do to drive that change? And, luckily for me, landing on the job that I did with the leadership that we now have in the city, Thrive is really spearheaded by the First Lady, obviously also the mayor, who have personal stories to tell about why this is important to them. But this bold vision, this bold sort of paradigm shift resonated with why they were in politics, why they serve in city government, in terms of empowering communities, in terms of creating equity, in terms of using the levers of city government and how it touches people to advance opportunities for people. And so we described a vision of mental health that really fit needing those kinds of solutions, needing that from government to change things. And I think there's sort of a subtle theme that I'm hearing in the group, maybe because I'm wanting to hear it, that we have to both think broadly and boldly, but really also act locally and granularly. And cities and local governments are uniquely capable to drive that kind of agenda. It's very hard to drive that kind of agenda, as well as you're doing, at the federal level, or even at a state level in the US. We have under-resourced, undervalued the importance and the unique position that cities and local government can take in driving that kind of agenda. They know their neighborhoods better. They deliver services to their community. They're more used to working cross-sectorally, education, police, economic development, sitting at the same table with health and so forth. So I think in some ways that's how this got traction, is because it lived up to what cities can do, and really many stakeholders saw themselves in it. So that's the picture we painted, and we were able to then organize our work against what we defined as 6 key principles of action, 6 key lanes of change that we thought cities and this city could really start showing how they could look different. I'm not going to go through all of those categories. The 6 principles were to change the culture, act early, use data better, close treatment gaps, partner with communities, strengthen government's ability to lead, and there's another one that I can't remember. But all of our initiatives were derived from those key strategic lanes. And it isn't that we picked the 54 initiatives that are going to solve all the problems, but they're already starting to show new realities, what new could look like, and that the laws of physics allow this kind of difference to happen, and that hopefully will make the case for them and bring other people along to do more of it. To give you a little flavor of the breadth of this ambition, those initiatives include things like training 250,000 New Yorkers in mental health first aid, to equipping all of our public pre-K and public daycare staff with socio-emotional learning skills, so very much at the acting early stage. Making it a goal that every woman gets screened and treated for depression, pre or postpartum depression. Looking at the different ways our city agencies can collaborate to fill in the gaps for seriously mentally ill who fall through the cracks, who get caught up in the criminal justice system, homelessness, et cetera. So really trying to look at the fullness of government to create a system that takes the problem in on its whole. It kind of inhabits so many parts of the diagram that Pamela put up there. It really realizes that that's the spread, that's the scope, that's the places that we need to act on. I would say that despite 54 initiatives and this multiplicity of effort, a really key driving idea is the one you mentioned about task sharing. This idea that we have to make it not only possible, but the new normal, the path of least resistance, for as many people and places as possible are part of doing the work of mental health. And really expand the net of who has skills, how they interact with each other, and how the treatment system partners with others to enable them and benefit from their involvement in the work. And that's really a big learning that we got from the rest of the world, really deep evidence based on task sharing. This general idea has caught on, this idea that you can have a kind of principle-driven, strategic public health approach that's driven locally. We got inquiries from a lot of cities and counties in this country, and it led to a meeting that then now led to something called the Cities Thrive Coalition, which is now over 200 cities, I think, and local governments, really trying to understand what they can drive at a local level and to use our principles as kind of a shared framework of thinking and action and sharing best practices to do that. Thrive London was just launched. I don't take personal responsibility for the branding. There are other European cities and increasingly some other cities who are interested in this approach. And I just want to end with the notion of why, another reason why I think it's caught on is what we called it. I can't tell you the conversations of what are we going to call this? The New York City Well-Being Plan, the mental health plan for and you know, I hit on Thrive because it was a word that was not associated with mental health. It should be, and we just wanted a word that no one could be against, and that everyone can feel was owed to everyone else, the opportunity to thrive and to frame our work in that expectation and that aspiration was, I think, also part of what has ignited the imagination of folks to do different.
Thank you, Gary. Thanks for taking us through that journey and you know, just the scope and the scale of what you've been able to achieve is really amazing, and it's an inspiration to all of us to push the boundaries a little more and do the same things that you've done in our cities as well. Thanks. I'm going to now ask Thara to share her story. So just to give you an idea, India, as you know, is a very large country, huge population. Mental health had not been a great priority for many, many years till recently. We now, of course, have a new Mental Health Care Act, and many people involved are here in the audience as well. We have a fairly good district mental health program in place, not necessarily in action, these are very recent developments. There was a time when nothing much was happening, and that's when Thara with SCARF stepped in and really brought mental health into the forefront. She has done some exemplary work, which I would want her to share, but to also say that in addition to being, you know, mental health and severe mental illness being a big issue in cities in India, conditions like diabetes are another huge problem. South Asians are more prone to diabetes than any other population in the world. So comorbidities is something that she has been dealing with using very innovative methods of continuity of care, including telepsychiatry. So I'm going to ask Thara to talk a little bit about, you know, managing comorbidities in the population of people with schizophrenia that you deal with and other severe mental disorders.
Yeah, thank you. When it comes to managing comorbidities, I was a little disappointed today because we really did not see infectious disease. When you look at a country like India or even Africa, we are not just seeing NCDs. We are not just looking at diabetes or hypertension. Of course, they're all there. But see, I have completed a 35-year follow-up, a prospective follow-up, a first episode schizophrenia persons with schizophrenia. And I have lost 1/3 of the sample. 1/3 have died. And what did they die of? We still do not know very clearly. We still do not know what they died of because there are no proper medical records. The families are not always aware what the persons died of. But I do know that a substantial number died of infections like tuberculosis, malaria, even common viral infections which went untreated. So just from this morning's discussion, I had a feeling that we are placing a lot of maybe undue emphasis on NCDs, which may be more relevant in this part of the world. But when you go down south, as you say, it really becomes infections, inflammatory problems, compounded by the fact that there is an appalling attitude of my medical colleagues to treating the physical health needs of our patients. I mean, it's simply appalling. They just don't care. They don't believe them in the first place. And the standard of care that they provide for the mentally ill is so poor, so poor. Just because of their attitude, it's all in their heads. You know, there have been many times when I have gone to the state hospital to look up my patient, acute appendectomy, and I found him lying on the floor. The doctor has not even examined him. Why? Because he's a mental patient. So I think when you talk of morbidity and mortality, we have to really keep this in mind, and we just have to try and change the attitudes of our medical colleagues. I think training should also focus on that, because ultimately they are the ones who are going to deliver the care for physical illnesses. We can shout from the rooftops about diabetes and hypertension, but we are not going to do it. So I think that is an important aspect that we should keep in mind, especially those of us who are from Africa and Asia. The other problem is, of course, there's youth everywhere. Youth-related problems are more or less the same. But I would, however, like to emphasize that women in India are, women are so fascinating in many ways. But, women... But women with schizophrenia in India are a great challenge. Challenge because the social factors really come into play when you are handling, when you're trying to manage women and help them manage their lives. For example, in India, marriage is a big deal. You know, I mean, why do you get married? When do you get married? Who do you get married to? Do you even talk about mental illness when you get married? I mean, these are all issues that many of you here may not be very familiar with, but for us, it's a huge problem. You know, it's not just her delusions or hallucinations, but it is her social life. It's her family life, her personal life that becomes extremely important. And we have done a lot of research which clearly shows that more men remain single, but more women get married, but they also get separated or divorced. Hardly a divorce, nothing legal really happens, but they're just pushed away and say, go back to your family, go back to your parents, and live there till you get better. You know, so that's it. So this is another challenge that we face, we have been facing all along while we are trying to help persons with severe mental illness. You want me to say something else?
Yeah, I just wanted you to talk a little bit about continuity of care that you've been able to handle.
Yeah, at SCARF, you know, we provide a whole range of services starting from early intervention. And again, in India, and I'm sure that's true of Africa as well, early intervention is a very tricky thing. How early is early? A person with psychosis comes to you with a duration of psychosis of 4 years. Because of his explanatory models, he has gone to, you know, magical religious people, he has gone to temples, and you see him when he's been sick for like 4 years, and how do you provide early intervention at that point in time? You know, so again, that's a challenge for us. But nevertheless, we do have an early intervention service for people who do manage to reach us early enough. And then we have services for short, what we call not very long-term ill people. We do have services for them, but we also have a lot of aggressive psychosocial programs for people who are moderately disabled, not very severely disabled, whom we are able to get back and give them some employment, and we are able to put them, kind of mainstream them into life. The advantage being that 95% of persons with schizophrenia or severe mental illness in India live with families. So you can kind of take advantage of the resources that families can provide in many ways. And then, of course, we have long-term patients. See, I want you to understand that there is no, we still, although the new Mental Health Act envisages insurance, till today, mental illness is not covered by insurance. Okay, even if you had depression and you broke your feet, if you had one antidepressant in your prescription, you're not going to be given the money, right? So there is no mental health insurance. There are no great welfare programs happening in India. So there's practically nothing, just in terms of state support. There are no alternative housing available that you have here. You know, we don't have that many housing facilities in India. So you stay at home, you make it or break it. You know, you take up a job, then you do something. Otherwise, you are really relegated into the background, even in your own homes, and your family rejects you. So these are, what I'm trying to say is whether it is a youth or the women or the chronic mentally ill, it is a social issues that are really so overarching. And we can't just be clinicians and look at only the symptomatology. We need to look into all these aspects, and only then can you deliver a very total and comprehensive care to our patients.
Thank you, Thara. Thanks a lot.
Do we have time to take a couple of questions from the audience? So we'd like to open it up, and maybe if there are a couple of questions that y'all would like to ask of the panelists. In the interest of time, if we could probably have a couple of you ask the questions, and then we'll open it up to the speakers, that would be wonderful. And if you don't mind just introducing yourself quickly as you ask your question.
Sure. Hi, I'm Manisha. Thank you for all the great comments. This was very helpful. I'm just curious, in many of your fields of work, particularly in countries like India and Africa and the work that you've been doing, how have you sought to overcome stigma? Because from my experience, it's even hard to get people to come to the table to explore some of these initiatives because of the stigma associated with mental illness and their families. And then second quick question, if you have any thoughts on, in the absence of government funding being available, have you explored any sort of self-sustainable, market-based approaches in creating sustainable models for providing community mental health? Thank you.
Thank you so much. We'll take one more question, please, and then we'll move to the answers.
Hi, my name is Victoria Leonard, and I work with the Global Mental Health Program, and I also am involved with several women's health programs in Dar es Salaam, Tanzania. Thank you all for being here and speaking so openly. Religion was a topic that came up in almost everyone's speech, and I believe it can be a huge impediment or it can be a huge boon, a really space of healing, a space of help, a space of community. If anyone wanted to speak further on that, I would love to hear more.
Thank you so much. We're going to open it up to the panelists if you all would like to respond to that. And just to give you all a sense of time, we're a little bit tight on time, so if you don't mind keeping the answers short so that we might be able to take a couple more questions, please. Anyone?
Okay, let me go. So thank you for the very good question. I will start with the aspect about overcoming stigma. I know this is a difficult topic about overcoming stigma, but what we are trying to do, like I mentioned about the young people, is trying to take the conversation that it's okay to have mental illness. Mental illness is like any other illness. And one of the big challenges we had with the young people is going to seek services within the general hospital or in a facility where everyone else is seeking for services. So the use of user-friendly, youth-friendly clinics is where services are provided under one roof. Every other service a young person requires can get there, whether they have issues about early pregnancy among the teenagers, issues about sexually transmitted illnesses, all those issues can be provided where they feel that they are understood. So the healthcare workers are also trained to handle the young people, how to address issues of attitude and prejudices. So that's one of the approaches we have had, that this is a space where young people can freely go without even asking them about their guardians, and they get the care, and then the other process can follow. The next question you mentioned about government funding, it's true that there are limited resources. It has not been put as a priority among the issues the government want to fund. And that's why we are saying the issues of taking advantage of other health platforms. It has not been easy because you go to the other health workers, to accept you that actually part of integrated services should include mental health services. You need time to convince them, but those are some of the approaches we are trying. If there's a provision of, because these resources are the same, so let's take an optimal use of these resources. So if you come for a diabetic clinic, why should you not be provided mental health services? So that's another approach we are trying to take. The issues of religion is working with the religious leaders because they are more trusted than us health workers by the people. So they become our friends, and it becomes our entry point. Thank you.
Thank you, Dr. Njuguna. Any quick comments from anybody else on the panel on this?
So when the question about overcoming stigma, so one of the things, some of the answers that you get when you go to the community is that the stigma is even worse than the disease itself. That is what they always say. So you realize that people don't have the information. That is the first thing. That is why their attitude is like that. So why not give them the information first, then you're able to change their attitude. So that is what some of the things that we've always been able to do in our communities. And the issue about the sustainable methods. I'll take example of Kenya. So in Kenya, we have the smallest health units whereby we have these community health volunteers. They know each and every route in the community. They are assigned different locations, and even they know everything that goes on in the community. They know who and people like that. So something that is taking place is that these community health volunteers are also going to be trained on how to identify some of the mental health disorders that people have in the society. And then the issue of religion, like I mentioned, when you talk about religion, that is the first place that people will always go to. They feel that it is a safe space for them. So working with these religious leaders, like Dr. Njuguna said, is a very key point and a key entry point, whereby they should also be trained on identifying this is what religion can do, and this is what needs to be referred to a specialist.
Thank you, Yvonne. Thanks for that.
I think we would love to take more questions, but we are getting the signals from the side here that we need to be wrapping up. So what we would love to request you is that right after this, if it's possible to continue the conversations. Sorry about not being able to take more questions. We'd like to mention, first of all, thank you very much for all of you to join this conversation. As we mentioned at the beginning of this, that the spirit and the ethos of this conference is very much about practical action and how can we take all of the things that we've been talking about into all of our work going forward. We didn't touch on a number of different topics in this session, but there'll be a lot of parallel sessions, the important role of professionals, practice transformation, number of different areas that we will be taking on public-private partnerships and many other work that's happening where cities can play a key role. With that, Prabha, if there's anything that you'd like to...
Fine.
Okay.
Yeah.
So thank you so much. Thanks to all of you, and thanks to...
So thank you so much. That was very, very interesting. I hope that you're all enjoying the conference so far. It is my deep pleasure and great honor to now introduce you to one of our spotlight speakers. Elizabeth, or Betsy Bradley, is the president of Vassar College, and we are extremely excited to have her with us today. So, ladies and gentlemen, Betsy Bradley.
Thank you, Pauline. Oh, thank you, Fountain House. What an incredible event this is, and I'm just so honored to be here. So wonderful. I also am really honored to have met Ellen Sachs and to have seen Dr. Tedros. That was wonderful, and I can't wait to hear Vikram Patel speak. I want to do a little shout out to students who are here. How many students do we have? Great. How many Vassar students do we have? Yes. So I'm so excited that young people are really getting involved and are taking action and thinking hard and will help lead us. I also want to give an enormous thanks and shout out to my collaborator, Angela Afori-Atta, who is right over there, from Ghana, one of the smartest women you'll ever meet, one of the most strategic women you will ever meet. I'm not sure Ghana would have had a modern state-of-the-art mental health bill if it were not for Dr. Afori-Atta, who is now the, yes, who is now the chair of psychiatry, although she is a psychologist at the University of Ghana Medical School. Thanks for being here. Okay, let's see how these move. Okay. Oh, that's not the beginning. Yes, the beginning is with epidemiology. So I want to talk just a little bit about innovations in global mental health, particularly in low-income settings, and I want to use our work in Ghana as a bit of a case study. So starting with just the epidemiology, as we've already heard at this conference multiple times, about 20% of adults have moderate or severe psychological distress in Ghana, given, this is not WHO data, but a variety of different studies that have been done in Ghana. Importantly, that psychological distress, mental illness, et cetera, is really associated with unemployment and underemployment. And it's linked, as we've heard in many other contexts, with poor social support, trauma, substance abuse, et cetera. In addition to this substantial burden of illness, the treatment for this is highly limited. Access is poor. About a quarter of those with serious mental illness get treatment. And for those who have more moderate conditions, far less, estimates of a 98% treatment gap in Ghana. And even with serious mental illness, for those people who are hospitalized, medication availability and choice